Thank you very much for the invitation. I'd like to thank Dr. Al-Zabi and the conference organizers for inviting me to speak to you again. It's a great pleasure, even if it's a little early in the morning. As alluded to, this is a fairly complex topic, and it's made more complex by the fact that the data are extremely limited. And in some cases only available from press releases, which are not necessarily the best peer-reviewed sources for information. So I'm going to try to walk through this topic, which is, what are sensible precautions for COVID? Is there a place for monoclonal antibodies in the prevention of COVID in our patients? So just terminology, so we're all straight. Monoclonal antibodies or antibody cocktails can be used either therapeutically, so either as a primary or an adjunct therapy in seriously ill patients. And that's been the primary use for monoclonal antibodies up till now. Many of the manufacturers of these products are trying to expand that market into post-exposure prophylaxis, or more recently into pre-exposure prophylaxis, which are very different things. And one, post-exposure prophylaxis means you've had an acute exposure and you are trying to prevent disease. So you don't really need to worry about durability. Obviously, pre-exposure prophylaxis implies that you're protected for a much longer period of time, because most of us would not want to have an expensive therapy that only provided us with a benefit for a week or two. So I'll try to answer three questions. The first two are really more general, focusing on the role of antibodies in COVID-19. So are antibodies important in preventing COVID-19? Does passive monoclonal antibody therapy, prophylaxis, work to prevent infectious diseases? So is there a framework of knowledge that actually supports this activity? And is monoclonal antibody prophylaxis likely to work to prevent COVID-19, so pre-exposure prophylaxis? So to address the first question, are antibodies important? It's been increasingly clear, and this is a graph that was presented first by Dr. Dull at a COVAX presentation and subsequently published by Earl and his colleagues, looking at the different vaccine efficacy studies with very different products. And on the y-axis, you have vaccine efficacy, and on the x-axis, you have the neutralizing antibody titers relative to convalescent sera. And despite the fact that there were very different platforms, very different vaccines, there was almost a straight line correlation between the amount of antibody produced, neutralizing antibody in this case, and vaccine efficacy. So that, in fact, the neutralizing antibody titer explained about 80% of this curve. So clearly, antibodies work, can work. A second example of this was a study done by Florian Kramer and his colleagues, Dr. Leticia, presented by Florian Kramer at another COVAX presentation, where they looked at young Marine recruits, and they looked at individuals who had been infected before and individuals who are naive, but were in a very close environment. And what they showed was that if you were seronegative, you were much more likely to be infected. But if you had increasing levels of antibodies from your prior exposure or from vaccination, the risk of infection went progressively down. So clearly, antibodies from vaccination or exposure can be helpful. So antibodies are important, but are there any caveats to this question? Yes, because many asymptomatic people actually generate very low antibody responses. The highest neutralizing antibody responses are seen in the people who did the worst. They have the worst disease. And although there are some examples of people with primary immunodeficiencies who have severe problems with COVID, those who have agamma-globulinemia or hypogamma-globulinemia, so a complete inability or a relative inability to produce gamma globulins, they do not seem to be at increased risk unless they're also missing their T-cell responses. And overall, again, the studies vary in their outcomes, but overall, patients taking anti-CD20 therapies do not appear to be at risk from severe COVID-19. I've participated in several of these survey studies for several of the anti-CD20 therapies used in multiple sclerosis patients. And really, the profile is about the same. So antibodies are important, but they're not the most important thing. It's probably cellular immunity. Okay, so is there an intellectual construct, a practical construct for using monoclonal antibodies to prevent infectious diseases? And there's actually an abundance of evidence for passive polyclonal antibody prophylaxis for a wide range of infectious diseases, including viruses like rabies, measles, and encapsulated bacteria, of course. Palivizumab is the standard of therapy for preventing severe RSV in premature babies. Right? Monotherapy, it works. It's very expensive, but it works. Monoclonal antibodies, cocktails, were also used post-exposure to prevent the acquisition of Ebola virus, first in the 2014-15 West African outbreak. And there are now people who are actually using monoclonal antibody cocktails to prevent HIV oral post-exposure in neonates, for example. So we do have a pretty good idea that monoclonal antibodies alone or as cocktails can be effective in preventing a range of diseases, including many viral diseases. However, I think it's really important to point out that polyclonal serum, by definition, there are many different antibodies against many different targets. Monoclonal antibody cocktail is usually targeting multiple different, at least epitopes, usually on the same target in the context of SARS-CoV-2. And a single monoclonal antibody is really a very narrow protection. So the young Star Wars hero could theoretically protect herself from lasers or bullets by moving the shield that she has, her laser, very quickly and very accurately. But it's much better to have the wider protection provided by cocktails or polyclonal sera, because a single mutation could in fact allow a virus to escape from a single monoclonal antibody. And that's what we are in fact seeing. So we're moving towards monoclonal antibody cocktails and away from single antibody prophylaxis. So is monoclonal antibody prophylaxis likely to prevent COVID? Well, the short answer is it certainly might have been before Omicron. And the longer answer is it depends. And so we'll go through that on the next slides. So we do need to discuss the different monoclonal antibody cocktails that have been tested well and licensed in a number of places. And I'll use the FDA as the main licensing body because they have actually been quite aggressive in moving some of these products forward. So the first one I'll talk about is, and these products have the worst names. They're almost impossible to pronounce. So I'll call this Kazimdev, which was originally called Regen COVID-2. But it's two non-competing antibodies that both target the SARS-CoV-2 spike protein. And in non-human primates, the administration of these two monoclonal antibodies reduced viral load and prevented sequelae in non-human primates. In a phase 2 study of non-hospitalized patients, so these are patients who are symptomatic. So this is not prophylaxis. This is adjunct therapy or just plain therapy. They used 3 different doses, 2 different doses in this study versus placebo, and they found that there was a reduction of the viral load, particularly in those that had a high starting viral load and who had no prior experience with the virus. In their phase 3 study, they saw a 70% reduction in hospitalization and death in the patients. So these were outpatients with COVID who were given this monoclonal antibody cocktail, and they seemed to do better. The in vitro data suggested that this antibody cocktail was reasonably good against a range of variants of concern. However, that was until Omicron. And the current data in vitro suggests that this combination of monoclonal antibodies has almost no activity against Omicron. The second combination, it started out as a single monoclonal antibody, BAM, I'll call it. It was eventually paired with etesevimab, I'll call it ETE. This has had a bit of a spotty history because it started out as a single monoclonal, and in a phase 2 study, and again, non-hospitalized COVID patients who are randomized to receive 3 doses, they found no reduction in viral load, but a 70% reduction in hospitalization. And then it started into this approval history where it was initially approved by the FDA in November 2020. And then when there was variant resistance, the approval was revoked. BAM was then combined with ETE in February 2021. And ETE was a non-competing monoclonal antibody, again, targeting the spike receptor binding domain. In a phase 2 study, they found 70% reduction in hospitalization in these non-hospitalized COVID patients. However, when beta and gamma started to dominate, once again, the FDA revoked their approval in June 2021, and then it was reinstated when it was discovered that there was activity of this combination against Delta. So on, off, on, off. Let's move forward. Okay, another single monoclonal antibody that's more recently available called sotrovimab, GSK and Vir Biotechnology. It's also got an almost unpronounceable proprietary name, Zvudi. It also targets the spike protein, and it does have in vitro activity against a range of variants, including Omicron. In this phase 3 study, one single intramuscular dose, again, of COVID patients who are not hospitalized versus placebo, it reduced the risk of hospitalization and death by about 85%. However, just to point out, there's no mention of prophylaxis in the product monograph. And this is true for all but one of the products that we're talking about. And of course, there are other therapeutic monoclonal antibodies approved or in trials around the room. I've just mentioned two of the, around the world. I've just mentioned two others here. A very recent entry, this was just licensed by the FDA in December, is the AstraZeneca combination of tixagevimab and sigalvimab, again, totally unpronounceable names, which forces you to use the proprietary name of Evusheld. Once again, these two monoclonal antibodies are they target non-competing epitopes on the spike protein, and they're given as two separate injections. But these are very different antibodies because they are long-acting. They have been modified to reduce the FC and complement binding characteristics and to dramatically increase the durability of the presence of these antibodies in the serum. In their phase 3 study, 2-to-1 randomized versus placebo, they saw 77% protection against symptomatic COVID for at least 6 months. And based on the antibody kinetics, they are predicting that there will be protection for out to 12 months. And I reiterate, this is the first study of true pre-exposure prophylaxis where we actually have some data. And so this was the first FDA licensed monoclonal antibody cocktail for PrEP. It did show good in vitro activity against a range of variants, again, including Omicron, which is very interesting. These antibodies are very different from the preceding antibodies. And I just want to walk you through how they were produced, because this is the brainchild of James Crow Jr. at Vanderbilt and some other people working around the world. And this is the idea that you can take a survivor who volunteers to give you some blood, you isolate the B cells from that survivor, and then you screen the individual B cells for their production of monoclonal for the production of antibodies from individual B cells, which are, of course, by definition, then monoclonal. You identify those that are strongly neutralizing, and you isolate the genetic information from that B cell that codes for that antibody. You then use a variety of expression systems to make large amounts of this now fully human monoclonal antibody that can be used as a product in this case, pre-exposure prophylaxis. This is a really different way of generating monoclonal antibodies, and it actually is derived from the same groups. This is James Crow's work in Ebola, where they actually took Ebola survivors and they did exactly the same thing, but rather than putting the DNA into an expression system, they put it into an adenovirus or a Venezuelan equine encephalitis virus vector and delivered it intramuscularly into a naive subject. And then the transfected cells in that individual would be producing this fully human and highly neutralizing monoclonal antibody. There are many other candidates like this that are moving forward into clinical trials. And I think that we will see this concept of vaccine immunoprophylaxis either with the production of the monoclonal antibodies in ex vivo expression systems, or in a more sophisticated way with these viral vector delivery systems. We will see this more and more, and particularly in outbreak situations. So this is actually really very promising. Okay, so what are the actual licenses that these products have for treatment? Well, the first three that I mentioned, the Cas-Imdev, the BAM-ETE, and the sotrovimab, are all licensed for treatment of non-hospitalized subjects over the age of 12 years who have had symptoms for less than 10 days. People are using these things as post-exposure prophylaxis, but that is an off-license use. The only product that is licensed in the United States for pre-exposure prophylaxis is the last one, the AstraZeneca product, tixagevimab and cilgevimab. I've also put the cost of these products where it's available up, and they are very expensive products. I couldn't find a cost estimate for the AstraZeneca product yet because it's all been purchased by governments. Just a few data slides here, and almost all of this data is in preprint form. Some of it has recently been published in December in journals like Nature and others, but it shows you the incredible change that has occurred with Omicron. So Omicron has, on average, about 36 mutations in the spike protein, many of them in the receptor binding domain, many in the adjacent regions. And you can see here a molecular model of the top of the spike protein, color-coded. And on the top, you can see a bar of many different monoclonal antibodies that are known to bind to specific epitopes, specific regions of the spike protein. And as you move up, as the bars get larger, the top of this graph indicates a 1,000-fold reduction in the neutralizing capacity. And most of these monoclonal antibodies are topped out, which means that they are at least, that their efficacy in neutralization is reduced by at least 1,000-fold. It is quite interesting that there are a few of these monoclonal antibodies that maintain some activity against the Omicron, but most of them have lost a massive amount. Here is another example, and it shows the sotrovimab results on the upper left-hand panel, and at the bottom left, where I've indicated the arrows, you can see the neutralizing activity as the curves go up against the ancestral or Wuhan form in the open circles, and in the purple circles, you can see the neutralization, the amount of monoclonal antibody that actually takes to neutralize the Omicron variant. And you can see that virtually all of these monoclonal antibodies have lost 2, 3, 4 orders of magnitude neutralizing ability against Omicron. However, as I said, the sotrovimab has maintained a fairly good, actually, neutralizing activity. And in fact, the new product from AstraZeneca also has activity against Omicron, at least in vitro. There is evidence that broadly neutralizing antibodies, and remember, broadly neutralizing antibodies come from exposure to natural disease and then vaccination, or vice versa, vaccination and natural disease. And this is a lovely study that was just released in preprint form as well, that looks at different categories of people. So on the top panel, you see convalescent, you see the different mRNA vaccines, the AstraZeneca Oxford vaccine, the Sputnik vaccine, and one of the Indian vaccines. And you can see really dramatic drops on the left from the Wuhan neutralization down to the Omicron neutralization. And the percent numbers at the bottom of this top graph are the proportion of individuals who have gone from being positive for the Wuhan to being essentially negative for Omicron. So no evidence of any activity against Omicron. So you can see that there is still some residual activity, particularly in the mRNA vaccines, but you see a 50 to 60-fold reduction in the neutralizing ability of these antibodies induced by vaccines. At the bottom left, you see healthcare workers. On the bottom right, you see dialysis patients who've been vaccinated after having disease. And again, you can see that this combination of vaccination plus disease results in a much broader antibody response and, in fact, a much smaller drop in the neutralizing ability of the antibodies produced when you go from Wuhan to Omicron. So the breadth of immune response is actually very important to protect against Omicron. Just before I finish up, it is also really important to consider the fact that these monoclonal antibodies are potentially quite, there are risks, long-term risks to using them in the context of actively circulating COVID disease, actively circulating SARS-CoV-2 variants, because you are initiating an you're providing an immune response that is very narrowly focused. And in the original SARS-CoV-1, there was clear evidence that with some of the therapies, some of the vaccines, you could actually put animals, in this case at risk for vaccine-enhanced disease, when they were subsequently exposed to the wild-type virus, a different variant, perhaps seeing it for the first time. We've been worried about this from the beginning. We haven't seen it so far in any of the vaccine studies being conducted to date. But if we start giving people narrow protection with these monoclonal antibodies in large numbers, we really don't know what we will see. And it is of interest that the Vanderbilt group has specifically modified those monoclonal antibodies that they've generated from survivors in an attempt to prevent this vaccine-associated enhanced disease risk. So they are thinking about it, but obviously only time will tell. Vaccine-enhanced disease was only seen in the SARS-CoV-1 animal models after 9 to 12 months. And really, we're only entering into that phase of the SARS-CoV-2 post-vaccination world now. So are there any good data on post-exposure prophylaxis for these antibodies? And the fact is, there really aren't. There are many trials that are ongoing, and Eli Lilly has published their study design for BAM-ETE, but getting really good data is very difficult, with the exception of the AstraZeneca product. All of the other product monographs either do not mention prophylaxis or state specifically the applicability of these findings to a prophylaxis or treatment setting is not known. Okay, so they're covering their bases. They know that many people are using these drugs off license, and they want to make sure that they are not promoting that use. Okay, so the last three slides. What is the marginal benefit of spending perhaps several $1,000s on top of a business class airline ticket for a monoclonal antibody infusion? Well, 3 doses of a decent vaccine. I just showed you that there was actually pretty good residual activity against Omicron. And I also showed you that for several of these vaccines, there is no activity against Omicron. And we have no idea what the next virus might be. We might not have a next virus, but we'll see. But if you have 3 doses of a good vaccine and adequate personal protection measures, what is the value of a subcutaneous or an intravenous or intramuscular monoclonal antibody cocktail before you get on the airplane? We just don't know. But we do know that it's expensive, and we do know that these infusions are not benign. Very few people have had serious adverse events from receiving these monoclonal antibodies, but many people do have systemic adverse events who have received these monoclonal antibodies in the clinical trials for treatment of COVID patients. have been seen. So in conclusion, and leaving a good period of time for questions, pre-exposure prophylaxis on license is only available for the long-acting Evusheld, recently licensed in the United States by AstraZeneca, and it is specifically restricted for those who cannot be vaccinated, right? You're not allowed to give it to people who just want it as a pre-exposure prophylaxis. Post-exposure prophylaxis, even though it is mentioned in many review articles, is an off-license use of most of these other products. And it can be considered for several of these products, but they are licensed as therapeutic adjuncts. Of these, only one so far, sotrovimab, appears to have any significant neutralizing activity against Omicron. And so one has to be very alert to the fact that these monoclonal antibody therapies, whether they are a single treatment like sotrovimab, or a narrow cocktail with two antibodies, you are relying on a very narrow, that Star Wars laser sword type of protection. And a single mutation could possibly allow the virus to completely bypass your monoclonal antibody protection. So my personal feeling is that while the new Evusheld has some real advantages and is a lovely new addition to the armamentarium for COVID, that really its primary use should be for those who cannot be vaccinated, as opposed to those who want a little bit of extra protection, because there is no guarantee whatsoever that a month and a half from now, we will not be dealing with the next Greek alphabet letter SARS-CoV-2 variant. And we've seen what the recent shift from Delta to Omicron can do to the efficacy of these products. Thank you very much for your attention, and I'd be happy to take